Hi, my name is Nicole Hong, and this is my review presentation on nutrition and health promotion in Asian American communities by community intervention and cultural adaptation. So there's a high incidence of chronic diseases such as cardiovascular disease, hypertension, and obesity present in the Asian American population. This can be attributed to the Asian American diet that is high in carbohydrates and sodium, low in fiber, and a greater use of cooking oils compared to the traditional Asian diet, which is low in fat and high in fiber and associated with a reduced risk of heart disease. There's also a disproportionately high rate of hypertension and cardiovascular disease control in ethnic communities, including the Asian American population. So, Asian culture is family and community oriented, and community based organizations are important for environmental and organizational change, which is why this review is digging into how community based and culturally adapted programs can help implement and change nutritional behavior in Asian American communities. There's actually a lack of culturally adapted programs and educational materials, which may make it harder for Asian American communities to be informed or make changes in nutrition behaviors. The first study examined the Reach Far program across different faith based organizations and their implementation process of health promotion activities to Asian American subgroups. Reach Far is the racial and ethnic approaches to community health for Asian Americans. It's a project that implements a multi level and evidence based health program and hypertension control program in faith based organizations serving Asian American communities of different subgroups across multiple denominations. 12 faith based organizations were assessed in this study, and the Asian American communities reached were Bangladeshi, Filipino, Korean, and Asian Indian in New York City and New Jersey. The program used the ecological validity model, which culturally adapts the program across congregation and faith settings. Several baseline measures were also used, and FBO sites to see Keep on Track program to monitor blood pressure, and measures in the study were culturally adapted as needed, such as incorporating cultural foods and language translations. This table displays findings from the Reach Far faith-based organization congregate surveys. The findings include social norms, attitudes, and access to healthy foods and beverages. And the findings in the red box show the attitudes of each group based on their perception of their overall diet, how difficult it is to choose healthy food options at community meals, and if several food items are usually or always available at their faith-based organization. So findings show that 14% of respondents reported their diet as fair or poor. And in terms of blood pressure, Bangladeshis were most likely to present as hypertensive, and Asian Indians and Filipinos had lower percentage of being prescribed blood pressure medication. This study examined the association between community-level intervention on food purchasing and preparation, nutrition knowledge, and health awareness in Asian Americans. It used the Ideal Reach program, which stands for Improving Diets with an Ecological Approach for Lifestyle. The purpose of this program was to increase access to an environment with healthy food or beverage options for Asian American communities, and the ultimate goal was to reduce the risk of chronic diseases within the community and improve overall health. The study reached 31 community-based organizations that serve Asian American communities, including Chinese, Vietnamese, Korean, and Filipino Americans in Philadelphia. And the goal was to reach individual community members, community organizations serving the community, and grocery stores. Questionnaires were used and included demographics, food purchases, food preparation and cooking practices, nutrition knowledge, program promotion, and use of media and social media. At the 12-month follow-up, 3 outcome measures were assessed: the purchase of low-sodium foods, the purchase of healthier oils, and the purchase of whole grain products in the past 6 months. This table presents the baseline and 12-month follow-up results for food purchases, preparation practices, and consumption. In the red boxes, it shows there is an overall increase in purchasing interval from baseline to the 12-month follow-up of many food items, including soy sauce, white rice, and cooking oil. There's a significant increase in using more whole grain and cooking, and an increase in subjects never adding salt to food. This table shows the change in knowledge of nutrition and health effects related to sodium, oil, and fiber from baseline to the 12-month follow-up. There were significant increases in knowledge of the recommended amount of physical activity for both for people with diabetes, the recommended daily sodium intake, the main source of sodium in the American diet, and the healthiest type of fat. The knowledge of sodium, fiber, and oil score were significantly higher at the 12-month follow-up. So there are improvements in purchasing behaviors, meaning subjects were not purchasing these items as often as they would be. There's also healthier cooking and consumption behavior, and a significant increase in knowledge of nutrition and health effects. There was also significant increases in exposure to signs that promoted healthier oil, whole grain, and low sodium products. So this last study is similar to the first, where the Reach Far program was used. However, most of the focus was on adopting, adapting, and sustaining the program. There were 26 community-based sites where 20 sites participated for the full 24 months. The sites included ethnic restaurants, grocery stores, and faith-based organizations. And the subjects within those sites were site leaders, managers, staff, and volunteers. And it reached Bangladeshi, Filipino, Korean, and Asian Indians in New York City and New Jersey. The study used a case study approach where key liaisons were used for project interest and feasibility. Interviews were also included, which had questions about motivation and partnerships toward adoption, experience with implementation, perceived program efficacy, and resources to sustain the program. The interviews were in the subject's preferred language, and the program had implementation components, which were examined for influence on outcomes such as adaptation, adoption, and perceived sustainability. This table shows the program components that sites selected for implementation from Reach Far. These include select food items and blood pressure monitoring and screening for faith-based organizations, menu, price, and meal changes for restaurants, and product and advertising options for grocery stores. Findings show that leaders in the sites resonated with contextual factors, um, which were implemented, allowed implementations of culturally adapted health behavior, and majority of sites selected nutrition components to promote healthy behavior change. In addition, program adoption, adaptation, and sustainability were based on several factors such as intervention characteristics, outer setting, inner setting, and characteristics of individuals. Overall, the studies show that community-based settings are an appropriate venue for nutrition and health promotion in Asian American communities. Adapting existing interventions can result in successful implementation and uptake of health promotion strategies based on religious and cultural preferences of Asian American communities. Community members have also reported a desire to improve their diet by enhancing cooking, preparation, and eating practices, and this is influenced by the desire of site leaders to address the health needs of their communities. Sustainability was executed by resource support and outside community involvement. Further research is warranted to implement strategies to improve blood pressure control and nutritional practices, as well as enhancing nutrition and health knowledge related to fiber, oil, and sodium intake, as well as health risks within Asian American communities. I personally would expand the target population and study different regions of the US and possibly regional diets within the Asian American community across the nation. And that is the end of my presentation. Thank you.